our last session on urogynecology. Let me ask Dr. Jane Depressed from Jan, I'm sorry. Excuse me, I'm sorry for that. From Belgium, he will address us about the simulation and training in urogynecology. Dr. Jan.
Thank you, Mr. Chairman. I mean, they usually make jokes with my last name, Depressed.
What's the last name?
Depressed, but I feel happy. Okay. So, a few words to start the day of the urogynecologist that is a properly trained resident. And I would like to talk to you about how we, in 1997, we did the first laparoscopic sacrocolpopexy, how we structured the training for the fellows. Then what is the value of a structured training program? And of course, laparoscopy has been replaced by robotics, but we will speak about training models and a problem that is coming, that is the volume for exposure. So laparoscopic sacrocolpopexy was introduced quite a while ago, so we have good long-term outcome data that shows that patients are improved in 85% of the cases and that the recurrence rate is very low. And this is really on the long term. So that is why it is worth learning it to other people. And so what we did is with the first fellow 15 years ago, we asked that the fellow would already be fully trained with laparoscopic hysterectomy, with endometriosis, and since suturing at that time was not really part of the curriculum, we asked the suture to do suture and training courses that were specifically for suturing, a course that is now part of the European training. And so what we then did is monitor our fellow during that learning curve, and we followed him for 60 cases, and we matched that to concurrent controls done by the supervisor. At that time, the learning curve was always defined by operation time. And indeed, several studies have shown that there is an effect of learning and operation time. But at the beginning, that was done in a very unscientific way. And you see here learning curves of 10, 15, 20, 30 cases. But the method that we used at that time was quite novel. And we looked at what is the effect on operation time and what is the effect in terms of complications. And so what we did is we divided the operation in a phase of the promontory, the dissection of the gutter and the vault, the fixation process of the mesh, then the fixation to the promontory, and the peritonealization. Because for these things, you have different skills. For all, you need to have stereotaxis. For the second, you need to be confident with the retroperitoneal space, which is not always the case for gynecologists. And then you have to be confident with dissection in an area where you usually don't come from above. And there is the problem of suturing, which now today is not really a problem anymore. And so what we did is we also did corrections, because not all sacrocolpopexies are the same. So it's dependent on the number of sutures or the extension of the dissection. And we measured next to time also the occurrence of complications, or for the assistant to ask for help to the mentor, and that would be considered a failure. And what we did see is we studied these 5 phases. We compared the operation time to that of the mentor. And how do you have to make an interpretation of this? This is what is called the moving average. This is operation time and cases. And 2 standard deviations under and below are considered as normal. And for instance, for the promontory, surprisingly, there was no difference in operation time. And the average was, after 20 cases or 40 cases, completely the same. So for the other steps, we discovered that dissection, it took 30 cases. For suturing, only 10 cases with this prior training. And then for the peritonealization, the same effect of the suturing. And the stapling to the promontory is such a quick thing that there is no difference. So that means that the real bottleneck of this operation is in the dissection phase. So as we concluded from that at least in our hands, around 30 cases, that this was very comparable to another operation that is happening in the retroperitoneum, and that is colectomy. This is certainly not a perfect study design. I will not go into the details, but it was meanwhile confirmed by others, and this is, for instance, a series from Lille in France, also promoters of sacrocolpopexy in the early days, and you can see here that the learning curve was also around 30 cases. And actually, remarkably, we can see that in three-dimensional surgery, you see an effect that is quite similar, but in that study, they actually saw it takes around 60 cases to have really a stable plateau, all depending on your prior training. And in robotics, that is usually people who have not done laparoscopy. This is on robotics, and you see here when a real novice starts to do sacrocolpopexy, that means no prior experience, you have a plateau at 60 cases, and you get proficiency at around 55, but what is called retention of skills and avoidance of complications, you need more than 84 procedures. This is very important because 84 of these operations, that means you have to have a certain volume. This has meanwhile also been studied for single orifice robotic surgery. And you see here that in this study, in surgeons that had already experience with robotic surgery in multiple ports, that they of course have a very short learning curve. There is also some data that show that really it makes sense to give a structured training program. And this was a study, for instance, that was on doctors who have assisted already 20 sacrocolpopexies. They were forced to first video edit surgeries from their bosses. They had to do a laparoscopic training course. And then you see that you have a shorter learning curve, and in this case it was around 18 cases. Also, specific trainers have been made for that. These are, for instance, in silico examples, and actually for that particular trainer, you can see here how the skills are acquired and how it has an effect on the operation time. Now, that brings me to another point, is that volume, 30, 60, 80 cases. Together with Professor Krofta from Prague, we actually looked at these problems. And in a country like ours, we're on line number 2, there are around 350 of these procedures per year billed to the government. So probably that is reality. And if it actually, the volume in the unit is around 35 cases, which was at that time our volume, and given that a resident in training is absent around 1 day in 2, it would take 2 years to train a person to be a complete fellow. That is really a problem. And this is the same for other procedures in urogynecology, like birch colpus suspension. How many birches do we still do? Can we still learn it to somebody? This is data on sling surgery. For instance, you can see here that in this particular study, that the number of people we train over the years has increased. That means that the demand is larger. And of course, your number of procedures will not follow that same pace. So we really create now ourselves a problem for training because the volume is not big enough. So either we have to restrict the number of trainees, or we would have to do more surgeries, which would be unethical. There are different models to train people. I mean, we have progressed. There are in vivo training models. We have, for instance, a vaginal sheep surgery model, which is in vivo. It's very debated, but it certainly mimics the anatomy. We did a comparative study between human anatomy, and in that model, it is quite challenged to do, for instance, laparoscopic sacrocolpopexy. these models are perceived by the trainees as very realistic, and it gives you really a good tactile feedback. Of course, over time, this will not be sustainable. They cost a lot, and there is a lot of criticism. So that is why inanimate trainers are needed. And for instance, here, this is not from us. These are videos from a training program where a in silico model has been made for robotic surgery. These in silico models can be very simple for learning the basic skills on the left-hand side, or in an operating room trying to mimic as much as possible of the operating environment, but without using humans or animals. Also, in the future, we will have simulators that are very close to reality. And this is, for instance, a study from last year where they mimicked the insertion of vaginal slings. And you see here how the operator gets feedback from the machine. And so that can be introduced into the curricula, but at this stage there are certainly some shortcomings because these models do really need some more improvement, tactile feedback. We don't really can learn everything, to my opinion, from those models. They lack actually realism today. Now, the last thing that will come and will be part of our daily practice, not only for trainees, but also for experienced surgeons, that is artificial intelligence will analyze our videos. And this is a study that we did in London where we looked at video recordings of sacrocolpopexis again, and the computer is learning itself about this. And what it does, it tracks all the trajectories of the instruments, which is very easy with the robot, but with conventional laparoscopy is quite new. And I don't want to bother you with the details, but it can analyze the operation, build it into different segments, and identify where the trainee is struggling with, so that additional training can be focused on that particular part of the operation. And we are doing this now for laparoscopic surgeries, validated in robotic surgery, and we are trying to do this with V-node surgery, which is also a kind of endoscopic operation. So to finish, I think for training, the subspecialty training, we have to offer skills trainings because you have seen it shortens the learning curve. A structured program really makes sense. The second thing is that there is really evidence that this matters, so it is unethical to have trainees starting surgeries without such a training. There is a volume problem because most learning curves in endoscopy are around 30 to 60 for novices, a bit shorter if you have prior experience and you move to the robot. But that means there is a volume problem. You have to have enough procedures over a short time if the training is only 2 years. The range of the training models is expanding. They are not all the same. They're not always affordable. So the authorities, the people that are making the decisions on training courses really have to make their choices based on the availability of the resources and the models in their own environment. I do think that in the future, this bottleneck of numbers is something that is separately to be solved because it applies to all surgeries, of course. And also artificial intelligence will probably help us to more structure the training because it will give us feedback on what the person really struggles with and what things that need less attention into the curriculum. Thank you very much.
Thank you very much, Mr. Dr. Deprest, for this very nice, interesting talk. And may I present our next speaker, is Dr. Jack Kozlowski from Germany. Okay, nice to meet you. And our next topic is pelvic floor sonography and post-operative complication management after sling surgery.
dear chairmen, dear colleagues, thank you very much for the invitation. Good evening. In next 50 minutes, I try to convince you why pelvic floor sonography is most important for the planning of postoperative complications management after sling surgery. Okay, now first we put the focus on discovering of sources of complications after sling surgery. And I would like to show you first a sonographic appearance of optimal position of TVT, its mechanism of action, and as well as the sonographic findings in case of abnormal position of the slings. And finally, I would like to clarify the significance of pelvic floor sonography in the management of complications in 3 cases. This man, Olmsted, 1996, presented a new surgical method for the treatment of female stress urinary incontinence, TVT. Olmsted, I try this again, show that the area between the knee and high pressure zone must be stabilization with the tape. Polypropylene tape with local anesthesia, without elevation, with cold test. And the middle third of ureter is most important. This doesn't work. And the most important part of the urethra is, you see, between knee and high pressure zone. And this doesn't work. Can I? Okay. Also presented a new technique, 1969, to treat for female stress incontinence, TVT. He said polypropylene tape with local anesthesia, with cold test, without fixation, without elevation. And he said, Babdel, he said that the middle part of the urethra is most important. The middle part between knee and high pressure zone need dorsal stabilization with a tape. The tape should be over there. But he didn't use ultrasound. He didn't see tape in vivo and behavior of the tape in vivo. And now I'll show you normal patient with normal urethral length after TVT procedure according to Olmsted. And you see, to illustrate the mechanism of action in vivo, what's happened with the tape during Valsalva, I selected a patient with a calcification of glands exactly in the place of high pressure zone, where according to Olmsted, dorsal stabilization is necessary. But you see, at rest, the hypoechoic tape is parallel to the urethra, but on a junction between the lower to the middle part of the urethra and far away from high pressure zone. Please observe the pulling direction of TVT during Valsalva. And you see, during straining, the urethra lowers in dorsal-caudal direction and it is pressed in the TVT, in the sling. TVT approaches the high pressure zone of urethra and assumes horseshoe-like shape on straining. You see a movement between urethra and the tape. And you see the middle part of the urethra with high pressure zone is stabilized by TVT only on straining, not at rest. And we know where is the optimal position of TVT and the junction between distal to middle part of the urethra. And we know that the dystopic tape placement too far distal and too far proximal, especially on the bladder neck, is responsible for recurrence incontinence. You see during Valsalva, opening of the urethra is its funneling persists distal to the tape moved to the bladder neck, and the woman loses urine on effort. You see all 4 people with recurrence after sling surgery. In all cases, you see the TVT on the bladder neck. The proximal part of the urethra is funneled, and the patient loses urine on effort. And this is the optimal position of TVT. The first question is, why all these things are close to the bladder neck? It's a failure of the surgeon, or it's a failure of the sling? Or perhaps, did they move towards to the bladder neck after implantation? To check this question, we make a study with 244 patients after TVT, and we check the position of a sling 1 day, 1 month, and 6 months later. And now you'll see what's happened. It is the position. It is the position. I show the position 1 day after sling, after insertion, over there. 1 month over there, and 6 months after surgery over there. You see, always there's the optimal position. That means if you find the TVT on the bladder neck, it's a wrong technique. It's not the movement of TVT. We have 4 parameters to check the tape, 3 of them in sagittal plane. First, it's a position of tape according to urethral length. Second, it's the shortest distance between hypoechoic urethra and tape. And you check the shape of TVT. It must be parallel to the urethra. And in axial plane, additional, the 4th parameter, that means symmetry of the tape. You need 2 planes. It's very important. Why? Because the urethra, the tape, don't touch urethra anywhere. Don't touch in this place, right and left, without touching. If you have a touch of the urethra with the tape, it's a cause of dysfunction of the overactive bladder, OAB, dyspareunia, and recurrence. You see, it's a C shape. It is the best side for the tightness. The tape is too tight. Or you see, only touching, asymmetrical placement, and with touching on the left side. And this patient has also overactive bladder, voiding dysfunction. And now, I will present you the importance of pelvic floor sonography for making decision in a handling of complications following after sling surgery. I choose, it's very easy, 3 patients without prolapse. All of them get TVT on the same day, and 3 women have the same problem postoperatively. The first woman, 6 years old, with urinary stress incontinence. In urodynamics, no pathology. No prolapse. Yesterday, she got TVT from you, and today, the woman say, I am happy. No leakage of urine, but now I have overactive bladder dry with frequency, urgency, and nocturia, and residual urine about 150 milliliter. And the question is, what now? And the same day, you make the second TVT, 50 years old woman, and the same problem, urinary stress incontinence without pathology, no prolapse, yesterday TVT, today happy, no urine leakage on effort, but you see the same overactive bladder, dry, and you see residual urine 150 milliliter. And the same question is, what now? And the same day, we performed TVT by 80-year-old woman. The same problem, stress incontinence without prolapse, yesterday TVT, today, no stress incontinence anymore, but overactive bladder dry and residual urine 250 milliliter. The woman is older, but the same question, what's now? We have 3 women with the same problem of de novo overactive bladder, voiding dysfunction after sling. Very easy question. You see, how do you deal with these patients? The same technique, the same patient, the same problems. That means the same surgery, recurrent surgery. Normally, you see, we have yesterday 3 patients, the same technique, the same indication, the same technique, the same surgeon, and we have some problems. And the question is, what do you do? Normally, you must perform the same technique to repair. You have TVT, the same problems, the same question, and you must say, okay, do the same in all 3 cases, like mobilization, a transaction, catheter, waiting. It will be better. More? More? It's a coincidence. Can coincidence decide which method you perform? Catheterization or tape mobilization? Or you can say, I put cut off transaction, but where? Midline, right, left, bilateral? You must remove, or you can say, we wait, it will be better. Or you can say, you must make yoga and we wait. Okay. No, in my clinic, no coincidence. Only precise diagnosis, objective diagnosis with pelvic floor sonography, and then cause-oriented method. You see case number 1, 6-year-old woman. You see the tape, and you see the more. You see the slight protrusion of the muscle. That's its cause of the urinary retention. Its type is too tight. What should we do? We open the wound, and you loosen the tape unilateral, on the right or left, only 1-2 millimeter down, and then you see no compression of the urethra, no residual urine, and the woman is continent. Okay. Second case, in sagittal plane, you see the urethra and the tape, and you see the distance is more like 3 millimeter. No touching to the urethra. Why this woman has an overactive bladder on voiding dysfunction without touching? It's not normal. But you see, we're still missing the second plane. In axial plane, look what's happened. You see the urethra, cross of the urethra, axial plane. You see the tape, left and right, you see the urethra touching on both sides to compare its optimal position of TVT without urethra touching. What can you do? This gap to increase, it's not possible. You cannot decrease. It's the wrong technique, too near to the urethra. What can you do? Remove, completely remove. In up first 7 days is no problem. No problem. Remove, wait 8 weeks, and you can perform second tape with correct technique. Okay, we have 3 women, the old one, the same problem. And you see, in sagittal plane, you see the same, the protrusion of the urethra, like in the first case. The question is, okay, we have the same problem like the first case, the same solution. Should we also perform the loosening of the tape or not? If you look carefully, and 2 places, 2-ax plane, you see small hematoma under the tape with a compression on a TVT and compression on simultaneously on urethra. This woman had a catheter for 2 days, diclofenac, ibuprofen, cholinergica, and after 2 days, there's only 1 centimeter hematoma. It's very, very small, but the incision was close, very small. And you see, we have 3 cases after the same technique, all of them the same problems. And you see we perform 3 various Hennig procedures. We didn't perform any standard method. Only following the findings with ultrasound, we choose cause-oriented procedure. In case number 1, with urethral protrusion, you see we choose sling mobilization. It's very easy. During the 7 days, it's no problem. In case number 2, with wrong technique, we had to remove the tape completely. And in case number 3, we perform waiting, conservative therapy with the hematoma, 2 days catheter, diclofenac, and waiting. The choice of the appropriate Hennig procedure always depends on the cause of postoperative complication. We need 2 planes, sagittal plane, and the second one, axial plane. And you see, in all these cases, I would prefer a different surgical procedure. This tape from the bladder neck must be removed. It's a wrong technique. This tape with optimal placement, but too tight. We must loosen. This tape with a touching on the left side, you cannot make trisection on the right side. The problem is left. You must make transection on this side. We have problem, left side. This tape with a very, very wrong technique. The tape must be removed completely, immediately. And in this technique, you see what's happened? The application, a tightening of the tape has been successful, not remove. You prepare, you must dissection with 2 suture, Eti-bond 2-0, it's no problem. If you have the pelvic floor sonography is not everything, but without pelvic sonography, everything is nothing. If you have a problem, you must perform ultrasound and look for an error. Thank you very much for attention. And for the technique.
Thank you very much for this interesting talk, it's very great. It's changed our opinion in many aspects. I mean, it's very nice. Avoiding dysfunction after tapes is one of the nightmares of urogynecologists. It's something that we don't ever like to see this after surgery. Yeah? And personally, if I see a patient with residual volume 250 milliliter after applying the tape, I won't decide twice. I will remove the tape immediately. I consider it as an obstructive case, and I won't hesitate in removing the tape immediately. But this changed my concept. Having an ultrasound, I discovered that it's small hematoma, and you do conservative treatment, and the patient improved after some time. So we can move to our next speaker in the management of female urinary incontinence, Professor Dr. عمرو خضير. مش موجود؟ إيه؟ So our next speaker, my dear friend and colleague and one of the best people I've worked with in the Urogynecology unit in Ain Shams University, Abdurrahman Safwat. Nice to see you, Abdurrahman, doing presentation about the genital urinary fistula, ending the silence and easing the suffering. The floor is yours, Abdurrahman.
Thank you, Professor Hazem, for this introduction. It's a pleasure to be here today with you. My dear professors, colleagues, and friends, I stand here honored and humbled to be a small part of ASOGIC. It has been a pleasure and honor to me to work with the amazing team of ASOGIC this year. First of all, I would like to express my gratitude to my mentors. Without them and without their help and support, I wouldn't have been able to stand here today with you. So very thank you. I would like also to express my gratitude to the wonderful team I'm working with. They always support me and help me. I'm thankful for this. So urogenital fistula, maybe you're asking yourself today, why are we talking about fistula today? It's just a rare condition. But allow me to show you a short video that will maybe convince you how urogenital fistula can be a disaster.
जङ्गलबाट आएपछि मलाई बिमार लाग्यो बिमार त्यसरी बच्चा जन्मियो अनि के थाहा थिएन अनि धेरै साह्रो बिमारी भयो 3 दिनसम्म बिमार लागिरह्यो 3 दिनसम्म बिमार लागिरहेपछि अनि त्यदेखिको पछाडि बच्चा पेटमै मरेछ बच्चा अनि पेटमा बच्चा मरिसकेपछि अनि म साह्रो भयो अनि पिरियड सुन्यो ठुलो भयो अनि यो खुट्टा नचल्ने भयो दाहिने खुट्टा नचल्ने भयो मेरो हैन नचल्ने भएपछि अनि त्यतिकै लडाइ राख्यो अनि अलिकति टाउको निस्केको थियो अनि म बेहोस भएपछि मैले केही थाहा पाइनँ हैन केही नथाहा पाएपछि बेहोस भएँ म एकदम पेट पोल्ने पैताला पोल्ने अनि त्यो जुन बच्चा जन्मिने ठाउँमा पोले गर्ने बिमार लाग्यो अनि लागेपछि अनि केही थाहा पाइनँ मैले केही खानु ओर्नु केही गर्नु अनि त्यो वस्तुहरू ब्याउँदाखेरि चाहिँ उसले त्यसरी ब्याउन सक्नु भने चाहिँ हात लगाएर निकाल्थ्यो अरे त्यही मान्छेले चाहिँ नि निकालेको छोरानो मान्छेले चाहिँ त्यसको भोलिपल्ट अनि सम्म साथी चाहिँ पेटमै थियो रहेछ अनि मलाई त अब थाहा भएन सानो थिएँ फेरि पहाडको ठाउँमा हो त्यस्तो जानकारी केही हुँदैन थियो हामीलाई अनि पेटमै थियो साथी चाहिँ अनि भएपछि अनि त्यो गाविसको अयबाहरू आएर साथी निकाल्यो 3 घण्टा लाएर साथी निकाल्यो अनि भन्दै थियो पछि दिदीहरूले अनि त्यो साथी निकालेपछि चाहिँ अनि दिर्सा पिर्सा एकचोटि डुबिरहेको थिएँ म भएर होस आउँदाखेरि चाहिँ थाहा परा पनि अब जान ठाउँै भएन पैसा पनि थिएन खर्च पनि नहुने कतै जानको लागि अब कहाँ यस्तो बिमार निको हुन्छ के हुन्छ थाहा नै भएन अनि उहाँको अलिक के 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 यस्तो छ उस्तो छ चाहिँ केही भन्नु भएन, एउटा औषधि लेखिदिनु भएको थियो।
So my friends, as I told you, fistulas might be really a disaster. So let's talk about the history of urogenital fistulas. But when we're talking about history of fistulas, we should mention the father of gynecology, James Marion Sims. He developed many instruments, operative techniques, and even positions for examinations just like this. And he have done a lot in the field of gynecology and especially urogynecology. But to be fair, we should also mention that many of his experiments and instruments were tested on enslaved women who were kept in a room in his garden, which is just a shameful story. Many people are trying to remove his name from history now.
Gynecology and procedures, and housed his slaves in the back of his house. What he called his medical suite was a shack, basically in the back of his home. He'd wake up in the middle of the night when he would, as he described it, have an epiphany in the middle of the night. He'd need to go in and grab one of the slaves and put her on the operating table. He would rouse Lucy or Anarcha or another without any anesthesia or the aid of any kind of pain relief. He would begin lacerating, cutting into their uterus, experimenting with C-sections on women who were not pregnant, cutting across their wombs over and over again to perfect what he was imagining in his sleep, essentially. Gynecology and procedures, and housed his slaves
Such a
in the
tragedy.
back of his house.
So what about Egypt? Egypt always play a major role in every topic. And regarding fistulas, here's Professor Yusuf Abdel Fattah, who was the first one to describe uterovesical fistulas, describing his Yusuf syndrome. And now let's fly to Europe, to Germany. What about the situation in Europe? What about the situation in developed countries? Is it only in Asia and Africa, or is this condition also possible in developed countries? So about 3 years ago, I was sitting in the emergency room when we admitted an 89-year-old patient complaining of urine retention and also continuous urine leakage through the vagina. Upon examination, I diagnosed a vesicovaginal fistula, which was actually a atrophic vesicovaginal fistula. She had a 3rd-degree cystocele that was causing her urinary retention, and she developed, because of the vaginal atrophy, she developed vesicovaginal fistula. You can see here, Hagar dilator passed through the fistula tract. It's actually not that big, but still a small fistula can cause a big problem. We treated her preoperative with local estrogen. You can see the difference between atrophic vaginal mucosa and after treatment with local estrogen. This is really important for post-operative results. Success rate increased a lot when using preoperative local estrogen. Preparing the patient is everything. Here's intraoperative. We have done cystoscopy. Here again the Hagar dilator. And now you can see the Hagar dilator from the cystoscopy passing through the vaginal wall and the bladder. As I said, small fistula, but make it a big problem. And it's not easy to do the surgery in such case because it was a little bit tricky. You had to do a fistula excision and at the same time handle with this cystocele to treat the urinary retention. So I've done Petrus flap, I've done an elliptical incision and total excision of the fistula tract, then sutured the bladder, and done Petrus flap, and then closed the vaginal mucosa. I've inserted then suprapubic catheter. Actually, this is my humble opinion. I find in fistula surgery, suprapubic catheter is much better for 2 reasons. Reason number 1, you don't have this friction between the balloon of normal Foley's catheter with the suture line of the bladder. And that might be a risk factor for recurrence or bad healing. The second reason, it's much better for bladder training 2 weeks post-operative before removing the catheter. And we have done this to this patient, suprapubic catheter for 2 weeks. 2 weeks later, we removed the catheter after bladder training. The patient were able to empty the bladder with no problem. We have seen the patient after that 6 weeks, 6 months, and 1 year after the surgery. And actually, I think 4 or 5 weeks ago, I had contact with the patient. She's now 92. She's very happy and have no complaints. And that's what I find really important about fistula surgery. It's just, we have to improvise. This is no standard surgery. There is no standard technique for every patient. You should just do the examination and see the best plan for each patient. There is no standard technique for fistula surgery. And whether it's vesicovaginal fistula, utrovesical fistula, or any other type of fistulas, rectovaginal fistula, even a small fistula make a huge problem, and it can be missed if we didn't do a thorough examination. That's really important to look for the fistula when the patient comes with typical problems and typical complaints. Before ending my talk, I would like to send you warm greetings from my colleagues and friends in Austria, the team I'm working with. So at the end, I would like to thank you all. It's such a pleasure and honor to be here with you, and such an honor to be a part of ASOGIC again. Thank you very much for everything. Thank you.
Thank you very much, Dr. Anna. Actually, we can reach the discussion now. We can open the floor for discussion. This was the last talk. So anybody of the audience would like to present a question? Can we have a mic here?
The second patient, yes, so the tape was on the left and right side during the implantation, too near to urethra, without touching to urethra. And if you cut in the middle, there's the left and right side push urethra high and open urethra. You cannot, if you cut the tape in a 6 o'clock, you cannot listen. If you put down, you can increase the distance on the 6 o'clock, but right and left, the distance is still the same. You cannot, if you release, if you put the tape, you put down, but left and right, the distance is the same. The tape is like that, you can put like that. You cannot increase to left and right. It is not possible. If somebody used wrong technique with the needle, you push up too near, too close to urethra, the tape stay in the same position all the time and touch urethra. If you make loosening, you put down, but left and right is the same distance. You must remove completely and wait, not in the same time another one, because the another tape is going to the same place, and will be take the same place. You must wait 8 weeks, and then you must put the another tape with a better distance. Normally, tape has about 1 centimeter distance left and right to the urethra. It is correct technique, and this is we remove. In the first case, we open the vagina. If the tape is symmetric, it doesn't matter right or left. You put the tape with a cover, with both hands, and you put down. about 1-2 millimeter. That's it. With both hands, it's very important because the first 1 second is very difficult. It's very difficult, and then you must put more on you hear this in surgery room, like, and then the tape you must put down from the tissue, about 1-2 millimeter, and close vagina. That's it. And she's continent. You must increase the distance. It's very important. The optimal distance is between 3 to 5 millimeter. Under 3 millimeter, the risk of overactive bladder, voiding dysfunction, and the pain is higher. And if the distance is more like 5 millimeter, no complication, but the incontinence rate is high. If you have low mobility of the urethra and the distance to tape is big, the urethra will be pressed into tape and is incontinent. The distance is very, very important. Too high is not good, and too closer to urethra is also not so good. It is very important to make objective diagnostic. If the doctors called me and say, I have problem after TVT, what should I do? I say, I don't know. I must see. I can tell you. You must see what's wrong with the tape. If you see the tape on the bladder neck, you must remove completely. It's not chance to change. On the bladder neck is wrong technique.
I have a question to Professor Deprest. You stated very nicely that with laparoscopic knowledge, you can easier do urogynecological procedures like sarcocolpopexy. My question is, do you need laparoscopic conventional training in sarcocolpexy, or can you directly go to such a suspension operation easier robotically?
Well, it's absolutely sure that people that are completely unexperienced with straight stick laparoscopy, and this is for colectomy, this is for robotic hysterectomy, etc. There are data that show that the learning curve obviously is much shorter, and therefore they will have a better performance on a shorter time. Does that have limitations? Yeah, that means that also outside a context of robotic surgery, those people will not feel at ease. Whether that will be a problem in the future, I don't know. The same can be said about open surgery as well. There is a whole generation that will not know how to open an abdomen anymore.
That's correct. I learned in older age to do sarcocolpopexy, had not done it conventionally robotic, conventionally laparoscopic, and I find it, of course, easier to do it robotically. More sure with the three-dimensional vision and all these advantages. Yeah. You agree?
Any other questions? Dr. Wafa? هنا.
For Dr. Jacek or Professor Jacek, I have two brief questions here. Thank you so much for your presentation. It was very nice, and it's always important to know the mechanics by the ultrasound for follow-up. It's really new for me. But my question is, how did you get this decision that we need to remove the tape? The same question here. Immediately the second day, because the distance is not equal on both sides. The second day there may be some edema, some tissue reaction, we may wait until the body and the tissue reaction can improve. It can improve with pharmacological, it can improve with intermittent catheterization. So where is the evidence behind that if the distance is not equal in both sides? Because I am revising my practice, how many of my patients I can guarantee that the distance is equal of the tape and between the tape and the urethra on both sides? This is the question. The other one about if there is any prolapse, anterior vaginal wall prolapse, which is sometimes it's hard to put the tape in the mid urethra. Do you usually do coincident, you treat both together or only one at a time?
Okay. The second question. If you have prolapse and incontinence, never, never, ever 2 surgeries in the same time. First surgeon is this prolapse surgery. Why? Because 85% women don't lose urine anymore after prolapse surgery. If you take the tape, 85% women get a TVT without indication, first. Second, in Germany, they pay only for one surgeon. They pay for prolapse surgery or TVT surgery, not for both. That means I use TVT not for money. And second question, TVT I make always, like Ulmsten, in local anesthesia with cold test, always. The position, the tape, to put the tape, this is 5 minutes. The most important is to tension free, and the woman is must cough. Same important. Prolapse surgery with full narcosis. That's why never together. Second, and it's very important to know how mobile is the urethra and how long is urethra before you decided which tape, TOT or TVT. This is very important. And after my prolapse surgery, I don't know what's an anatomy. I wait 8 weeks, I make the diagnostic, movement of urethra, length of urethra, and I make decision which kind of tape. There's another one. If you put the tape, I use always cold test, always. After TVT, all patients cannot lose urine. I put up until the woman don't lose urine. And then 1 day after surgery, I make ultrasound. And 3 to 5 millimeter is the optimum. Always 6, 7, 8 is okay. If you have a hypermobile urethra, you must always think the mechanism of action. The mobile urethra going down, it will be pressed to tape. If you have mobility like that, and you have a distance 10 millimeter, the urethra is not so mobile and get the tape don't touch the tape until you lose urine. The distance is very, very important. It depends of the mobility of the urethra. And if I see that the woman has a pain, overactive bladder, residual urine, and I see the distance lower 3 millimeter, you have only 7 days to change the distance. The most problem is you said to the patient, go at home and come back in 4 weeks, it will be better. It is the biggest mistake. After 4 weeks, you cannot move the tape anymore. If your distance 2 millimeter and you have problem, you have problem as like surgery. You cannot change the distance. You must remove the tape completely. This is wrong. If a tape at good position, not on the bladder neck, at good position, only the distance is too small, it's no problem. I put down 2 minutes. It's no problem. But you must trust your ultrasound. You must trust. You see distance lower 3 millimeter, you must change this. It's very important.
Thank you.
We remove approximately 400 tapes and meshes in a year. We have a lot of experience, but it's not necessary the tape to remove. If a good position on a distance is wrong, you can just change. You must not remove. But no mind tapes. They're coming from whole Germany to us. We have problem. I take about 150 tapes in a year, not so much.
How % of the tapes inserted would you consider as not inserted properly, that need to be removed here?
We make the mobilization about we have 150 patients in a year. About 10 patients in the year, we must loosen the tape, own tapes. Not remove, loosen. Remove, no. My tape, I didn't remove my tape.
No,
It is possible if every surgeons, my surgeons, must make this preoperative diagnostic and postoperative diagnostic. All surgeons must control own tapes postoperatively. And if you see your tape is on the bladder neck, you say, "Oh God, what I do?" You must remove, and it is only the first and the last time you can put on the bladder neck. Never. It's a wrong technique. You make the wrong the incision, wrong place, too long. It's a wrong technique. And you check your own tape, and you say, "Okay, my mistake. I remove." But that's finally, it's the last one. The another one, it couldn't be the same on bladder neck. It's not possible.
I mean, if we apply this theory, when applying a tape in an experienced surgeon, in an experienced center, it will end up that only less than 5% of the tapes need to be revisited by the ultrasound. Am I correct with this number?
Yeah. Ultrasound will make always.
No, I mean, but the positive data.
Okay.
The positive data you get in not more than 5% of
yes,
the cases.
okay, it's possible. Yes, okay, yes.
Excuse me, sir. Do you include the possibility of removing or release the tape in the patient consent pre-operative?
Excuse me, can you?
Do you include the possibility of to remove the tape or release the tape in the patient consent?
Remove only if you have wrong position.
And you include it in the patient consent?
In full narcosis. Not in local anesthesia. It is too painful. We go,
but
Do you
include this before?
yes, yeah. We talk about it. It's very important. It is most problem you have problem with a hypermobile urethra, low mobility of urethra. If you have this urethra, hypermobile urethra, you have no problem. The distance is 5, 6, 7, 8 millimeters. It works always. You have a low mobility. The distance is very, very important. My doctors, they make the first 20 TVT, never with hypomobile urethra. Always with hypermobile urethra. This is very important. It's very easy to care in a woman with hypermobile urethra, but it's very difficult with a slow mobility. It is distance about, it is very important, 1, 2, 3 millimeters. It is decided from the efficiency. That means I see the mobility, low mobility, it's a prophy. My prophy. And the beginner with hypomobile urethra is very important.
Can I just put a question to our colleague who presented the vesicovaginal fistulas? So, as it's so rare to get experience, I'm aware of 2 intraoperative occurring fistulas that we could directly repair. So my question to you is, if intraoperative vesicovaginal fistula occurs, it's mostly easy to repair, but what procedure would you suggest?
Do you mean, thank you for your question. Do you mean as a complication of the surgery?
With more sedation, for instance, we had a case where a colleague went into the bladder and out of the bladder. So these cases more occur in our world today than the obstetrical that you reported from Nepal. So your experience on correcting intraoperative lacerations like vesicovaginal fistulas, how would you go about?
Thank you for your question. As I said, it's difficult to give an answer that would fit for every patient. There is no standard. It depends how big is the fistula, what happened exactly, where in the bladder. Is it a deep, is it lateral, where is exactly the fistula tract? But in general, if it's intraoperative complication and the age is clear and this is the first trial of fistula repair, it's most probably that the surgery will just function. It's another totally other situation. If it's a recurrent fistula, then the success rate is not that high. And if there's like this case, atrophic vesicovaginal fistula, that was tricky because you're already starting with atrophic vagina, and his success rate is not that high. But when dealing with a patient with intraoperative complications or iatrogenic fistula, I think the success rate should be much higher compared to other cases with recurrence or atrophic vagina, or obstetric fistulas also are more difficult to operate and to heal. Thank you.